taken under the wing of a long-time athletic trainer for the Houston Astros. He'd been there for 30-plus years. The assistant had been there 30-plus years, and those guys scooped me up and attempted to teach me everything about baseball that they could, and for that, I'm forever grateful. I also learned very quickly that the work-life balance of an athletic trainer is sometimes very difficult, especially during the season. And in the 2 seasons I spent working as a full-time PT with the team, when something happens, there's nothing that you know, the timelines and when you want to go home. If a guy gets hurt, much like you guys, kid gets hurt, somebody gets hurt, you're not going to make what's on your schedule after that. So we also have a sports residency at Houston Methodist. I believe we're in year 12 or 13. We pair our residency experience with Rice University Sports Medicine, so our guys get to go spend time with the athletic trainers at Rice. They're there for football. The last 2 years, we've been able to send them over early. They're dedicated full-time to football camp, so they get to see what the life of an athletic trainer and being part of a sports medicine team at a collegiate level is. They put in the long hours. They're told by me, like, hey, you have to be the first one there. You have to understand, you know, to earn your respect in the sports medicine team, you have to understand what everybody's job is. Out of our residency, we've now developed an upper extremity throwing fellowship. We're in year 1 of that. We're a month and, or I guess 2 months, 3 months into that program, where we've kept one of our former sports residents, and now they're going to stay with us for a year to focus specifically on baseball injuries. Our residency, we've also placed 9 PTs in professional baseball, 2 in the NBA, 2 in the NFL, and 1 in women's professional soccer. So we're getting to teach kids and to be able to cast a net out there where these guys can get some pretty amazing jobs after their residency. So 2024 was the 50th anniversary of Tommy John surgery. Everybody's heard of that, right? TJ. It's very, very common, and what we're going to talk about is kind of how we get there, how we get to the point of tearing that ligament, and then what to do with it. And any of you guys, how many people in the room take care of the baseball team? So a lot. How many of you have kids that have had elbow surgery? Right? And the number continues to grow up, and we're going to talk about that. So as Jace, pointed out, it's been 50 years. I was born 1 year before that surgery. So most of my career I've been around this surgery, but what I can tell you now is the numbers of kids that we're seeing with these injuries has gone dramatically up, and we'll talk some about those statistics in just a minute, as well as why is that happening and what are we going to do about it, okay? Throwing creates a very high valgus load. It's repetitive loading, right? You don't just throw one ball, you throw a lot, and then the next day you throw a lot, and then the next day you throw a lot, and that's kind of the nature of the sport. But unlike other areas of the body, specifically the shoulder, we have a bunch of musculature that can help protect our shoulder. Rotator cuff, scap stabilizers. But in your elbow, if you look at the valgus stress on the elbow when your arm is laying back in a cocked position, the forearm musculature, it tries to help, but it has a limited ability to do that, okay? So what you get is micro trauma to the ligament with a lack of time for complete recovery, and it leads to attenuation over time through the ligament throughout the season. And we'll talk about a couple studies that took kids and looked at their elbows at the end of their college season, and then if they take time off, what happens to that ligament. And then what modifiable risk factors do we have that we can address with our rehab? So why are there so many injuries? These athletes are bigger, faster, stronger. There's a focus on strength and velocity in today's baseball game more than it ever has been. Okay, average MLB velocity in 2001 was 88.5. In 2023, it was 94.2. In 2024, it's 94. That's the average fastball. Very few pitchers now throw under 90 miles an hour. 103 pitchers in MLB in 2022 averaged 96 and above, and the top 3 were over 100 miles an hour. Anybody ever heard of Paul Skeens? Okay, guys throwing 100 miles an hour for the entirety of the game. Okay, so when I have these conversations with Dr. Lintner, Dr. Meister, who are two, Lintner is the Astros doc, Dr. Meister's kind of become the new Andrews, where that's where the majority of the professional baseball players are going to. we're getting to a point in a lot of these cases where we're exceeding physical capability. And as Dr. Lintner says, it used to be you had guys that threw in the 90s, and now we know that if we go through strength training and we take them through cuff programs and some of the velocity development, we can make kids throw harder. But the question is, can their frame withstand that? And in a lot of cases, the answer to that's no. Then you add on event overuse, the cumulative effect, and that gets us to kind of the current state of where we're at. If we look at professional baseball, 1/3 of all the major league pitchers have had Tommy John, and that's this year's number. Part of the reasons are higher velocities. There are some suggestions that the pitch clock has something to do with that, where they're throwing, they only have a short period of time to recover, go again. There's a lot of literature on pitch shape, talking about a sweeper, which is a kind of a hard slider where they're really, getting around the side of the baseball and imparting a more spin on it. It's a big strikeout pitch. But if you talk to professional guys who've had surgery, I had 5 of them recently through the summer, and they say that if they throw that sweeper, they can throw it only a couple of times a game because they feel it differently, okay? More than half of the UCL surgeries, this is the concerning part for me, because when I used to give this talk 5 or 10 years ago, the numbers would be 20%. Now we're looking at more than half the UCLs that are done in the U.S. are in the age 15 to 19 age group, okay? And that's most of what our kids are, right? And that's very concerning for a lot of reasons. So what's the mechanism of injury? Obviously, there's a volume and the loading, and we need to consider that for the injury, and we need to consider that when we're coming back from surgery. And we'll talk about the importance of a throwing program for that. What are the risk factors for UCL tears? How do we manage these kids conservatively, if they're even going to give you a chance to do that? And then what do we do with them once they've had surgery? What type of surgery do they have? Now we have more options than we've had in the past for these kids, okay? So what are we seeing in the younger athletes? Extreme overuse, a huge focus on velocity development, and then my concern there is that these kids are skeletally immature, they're physically immature, but they're trying to do things that exceeds the capability of their skeleton. Why does the medial elbow growth plate become an issue? Why do you get little league elbow? Because it's the same valgus stress when you throw the ball, but when you're a younger kid and the growth plate is still openly growing and widened, that's the weakest link. So that's the same thing that's the same stress that leads to a UCL tear. It's the same stress. It's the valgus loading. There's a lot of crazy parents, right? My kid can't take off. He can't miss this tournament. We've got to play every weekend. And these kids are getting a ton of mileage on them. We have 8, 9, 10-year-olds that come to us in the clinic that have played 200 games in a year. How many games is the major league season? 162. So we're going to ask an 8 to 10-year-old to play more games than we would a professional baseball player. What are they going to say? No way, right? How long is a college season, average? 60 to 80, right? So you're saying that 22-year-old kids are going to play 40% of the games that these kids are playing. And it's astronomical to see, especially in the Houston area, it's astronomical to see how many games these kids are playing. So from our side of it, the rehab side of it, what are we going to do about this? What can we affect to avoid these injuries or to rehab these injuries? Things that we look at are rotator cuff weakness, scap weakness, internal rotation deficit, decreased use of their lower extremity and core to generate power. Most of the younger guys, that when you ask them to throw harder, they don't drive with their legs more. They throw with their arm more. They over-rotate their trunk, which shows increased stress in the elbow. Okay, decreased balance. A lot of these kids have grown a lot or are still, immature. Their mechanics are not polished, and then you add all those things together, and that's a recipe for disaster. So our rehab has to address that, and we'll talk about kind of going through. We start very early with all of our UCL guys while you're in the brace, and you can only do limited things. We have you do body weight squats, single leg squats, single leg balance stuff, trying to develop a better core and lower half from the very onset. So kid comes in, says, my elbow hurts when I throw. What am I going to be looking at? What questions am I going to be asking? How long has your elbow been hurting? What position or positions do you play? Are you a position player and a pitcher? Are you pitcher only? Are you pitcher catcher? Worst combo. That's what I was. That's how I got hurt. Volume of play, baseball only. Are you playing year round? And then how much time do you take off? Because we know if you have a patient with an MCL, one of your kids has an MCL injury, grade 1 MCL, how long is it going to take that ligament to heal? 2 to 3 at the minimum, right? Up to 6 weeks. So we tell kids you need to take a period of at least a month where you don't touch a baseball. You're not throwing. That doesn't mean you're still going to your lessons. That doesn't mean you're still, throwing 5 days a week. It means take time off to allow that ligament to heal. And again, we'll talk about a study that shows specifically that. And then the other question, if they're non-op or I'm evaluating these kids, is where in your motion does it hurt? Okay? So if you're laying your arm back and you feel pain in your elbow, what do you think guys think that is? Ligament or flexor? When you're laying your arm back in its max cocked position, that's where the load in the ligament is the highest. So when I ask kids, and then as they're going through their throwing program post-op, I felt something in my elbow. Where do you feel it? Oh, it's when I really get out here and I flip, I get extended, I feel something, and then the next day, I'm picking up my backpack, sore. Those are all normal things. When your arm is in its cocked position, that's the highest load on the ligament, okay? So just a simple question that you can ask these guys to kind of start getting an indication of where it's hurting. So the majority of these are chronic overuse injuries. As we said, pitching a baseball generates huge valgus forces at the elbow. Those peak forces are at late cocking, and as they're beginning to accelerate their arm forward, and your elbow moves from a flex to extended position at 4,000 degrees per second. And if you look at the modeling studies of this, the load exceeds the tensile strength of the ligament with every elite level fastball. And elite level is considered 85 miles an hour plus. So every fastball they throw creates enough stress to tear the ligament, okay? Now the good news is you've got mechanics and your rotator cuff and musculature, your biceps and forearm that attenuates some of that stress. But the load itself is high enough. So we know it's a significant amount every time we throw a baseball, and then you do that repeatedly throughout a course of a season, and that's where we get problems. The other issue is early sports specialization. We are seeing a ton of mileage on these kids' arms. I mean, a ton of mileage. And you can't undo that at some point unless you're taking a break. So what does that look like? If you pitch year-round greater than 8 months out of the year, you're 5 times more likely to get hurt. I think it's an important education point for parents. I've been at it long enough. I've seen enough big-name guys, enough professional guys to have a little bit more confidence in telling these parents exactly what I think about it in a respectful manner. But, if the guys that I have that are making a living doing it wouldn't do it, why would your 12-year-old, 14-year-old kid do that? And why would we ask them to do that, okay? Here's the study I referenced. They took a group of Division II college pitchers, and the question was, do the adaptive changes in the UCL, the UHJS, which is the ulnar humeral joint space beneath the ligament, and internal rotation deficit of the shoulder, what happens if we truly take an off season? So they did preseason testing and then testing after the off-season rest period, and what they looked at and what they found is that the guys that had internal rotation deficit of their shoulder had an increase in their loaded ulnar humeral joint space. So if your shoulder was really tight, it also increased the likelihood that your elbow had more gapping at the end of the season, okay? And the UCL thickness was greater in pitchers with 10 degrees. So what happens after they rest? And they did this with an ultrasound. The UCL returned to its baseline thickness. It thickened up throughout the season in response to all the stress. And then take time off, allow it to heal itself. It goes back to its normal thickness. And there was a significant decrease in the valgus loaded and unloaded joint space. In other words, simply put, the laxity improved. So you give it time to recover, it can recover. It has the ability to heal itself. But interestingly enough, if you had a tight shoulder and you didn't do anything about it, that got worse. Okay, so then when you start back after throwing again, you haven't addressed that, then you're kind of creating that whole cycle around. So we start very early looking at these kids' shoulders, the ones that are tight. You've got to make sense. You've got to make sure that's a priority in that and do focused mobility work. So what do we do with the kid that has gone to the doc, they've gotten an MRI scan, it says partial UCL tear, okay? First and foremost, are they gonna, you guys know they've Googled it already. They've had buddies that have already had surgery. They think that surgery is the first answer. So the most important determining factor of are we gonna go the conservative route is, are they gonna give you the time or not? And do you have the time? Does a kid have 6 months in his baseball window, in high school baseball? Does he have 6 months to give it a chance? And then if it fails, then he may be having surgery anyway, okay? And then what Dr. Lintner will ask these kids is like, what's your baseball future? Like, are we going to do a major operation on you and you're not going to play again? Or do you have a chance to continue your baseball career? And then sometimes, I mean, if you're a pitcher, can you hit? Because if you can hit, then you can rest your elbow and you can DH and do other things. So if we do this route, there's a couple of different things, a couple of different studies that talk about this. You have to have absolute rest from throwing. That doesn't mean go on the side and play catch lightly. It means do not stress the elbow with valgus of throwing a baseball for a period of 6 to 12 weeks. In most of these kids, how many of you guys see PRP of the ligament? Handful, right? So the jury's out on this. PRP, stem cells, we see it. A lot of times if a kid's going to go the conservative route and it's a high-grade partial grade 1 tear, they'll do the PRP. I don't know if it helps or hurts. And what it does help us with is it makes their elbow really sore for a period of time, and then they dial it back for a little bit. So it kind of creates a window of rest for us. So during this time, we really focus on cuff, scapular strength. We work on internal rotation, range of motion, and as I talked about earlier, correcting balance and throwing mechanics. And in these kids, the most important thing, number one most important is the rest. Number two most important is your build-up, your throwing program build-up back to give them the chance. Because if you rest for 6 and then you just go guns blazing and throwing as hard as you can, then you're going to have a problem, okay? So what are the effectiveness of of the non-op UCL stuff? It's all over the map. It's roughly 79 to 80% with grade 1, grade 2s. And if the tear is in the proximal portion of the ligament, more on the ulnar side, or on the humeral side than the ulnar side, they have a better chance of healing those. And those, again, these most commonly in all the studies were treated with PRP and some rehab. As we move into surgical management, we're going to talk about all the difference of where we're at now, okay? So before, we only had UCL reconstruction as the gold standard, and now we have other options. So for your partial tears, we now have UCL repair with internal brace. Anybody seen anybody with that? Okay, handful of kids, okay? And we'll talk about what that is. A reconstruction in an elite level thrower, somebody that throws hard, a high level, high school or college pitcher or professional pitcher, the standard has always been to go ahead and reconstruct that ligament. Now what we're seeing is reconstruction with internal brace on top of that. And we'll kind of describe that, with what that is, okay? We're also seeing a huge jump in UCL reconstructions for the second time. So at the professional level, there's a bunch of guys, and I've had a handful of them, who have on their second TJ, okay? What we know about that, there's currently 45 of them in professional baseball with the second Tommy John. But look at the results. 62 to 68% of return to prior level, okay? So there's no guarantee with these guys. This is the UCL with internal brace. I'll see if I can get the video to go. This is on Arthrex's website. It's a simple, so essentially what you're seeing here is there's a collagen dipped fiber tape. So it's a fiber wire, very thick construct, very strong construct that's basically just put in over your native ligament. So they're just putting it on top of that. So you hear kids talking about, I had an internal brace procedure. This is what it is. They're putting it right over the top. They put a few stitches on there, and I'll show you, hopefully. There we go. Kind of what they do. There's 2 small drill holes at proximal and distal ends of the UCL. So they drill a small hole for the anchor. If there's a split in the ligament, they don't all look like this. Sometimes it's more of just a disruption of the fiber. So if it's a split, they will sew it back side to side and repair the ligament to tighten it up. Hole goes in the proximal end. And then basically you're just augmenting your old ligament. So for these guys, the rehab is a lot simpler. So if you look at timelines and return to play for an internal brace versus a traditional UCL reconstruction, the time's cut in half. And the reason that it's cut in half is you're augmenting the ligament with something that doesn't have to remodel. When we put a new ligament in, whether it's an ACL or UCL, it has to go through the period of tissue healing, right? That tissue has to mature and become a viable living structure, and you have to do things that build that structure up and that collagen strength up. In this case, they're not going inside the joint. They're simply augmenting the ligament that was there, okay? It promotes a much faster healing. So we've been seeing these for the last 7 years. It's an option for your high school kids that have the correct level of tear. So if you fully avulse your ligament off the bone, you're not going to get it repaired with an internal brace, right? If your kid blows their ligament up and there's nothing left of it, that's not going to be able to be augmented. But if they're a partial tear, then there's an option to repair that and be able to give them a predictable outcome. The long-term follow-up's still limited. We've only had 2 in the last 7 years, and they've been recently, that had this at some point in their career. One of them was high school, and his re-tear was in college. The other one was beginning of his college career, and then re-tear at the end of his college career. So I don't know what the long-term studies are going to show for this, but for your high school kids, if we can tell them, okay, you have a partial tear, we can go the conservative route, you're probably going to miss 4 to 6 months, and then you might not make it back. Or we can say, hey, there's a surgery, we can reinforce your ligament, we can tell you very predictably, at 12 weeks you'll put a ball in your hand, and by 6 months you'll be back on the field. Most people are choosing that option. Okay, so in the literature, 84% had no complications, 12% had minor complications, ulnar nerve, medial elbow pain, wound issues. 3% returned to the OR for nerve issues or to have their nerve moved. And then return to play was at 92% at the same or higher level of competition at roughly 6.7 months, okay? If you go to Dr. Lintner's website, we've recently updated the protocols for the internal bracing and the reconstruction hybrid technique that we're going to talk about in a second, and they're very, very specific. They've got a chart at the bottom that talks about what to do at what week, correlating with the healing timelines. So you can educate your kids on that. And I can send those to Sean as well, okay? So again, internal brace, much faster return to play. They usually have their normal range of motion by 4 to 6 weeks. Much less soft tissue swelling because they're doing less. The surgery is much more minor. And why is it faster? We don't need to worry about the graft maturation and healing. The throwing program goes much faster for these guys. So you can predictably tell your kids you're going to be back much quicker than if you have traditional UCL reconstruction. For the first 4 weeks, we're trying to get their range of motion. One thing that we're being careful with is they do split through the flexor mass, just like the regular UCL reconstruction, so you have to protect the flexor mass for a little while. But you can jump in right away with shoulder stuff. Again, you're not worried about internal and external rotation creating any valgus load to the elbow because there's nothing to heal other than the bone tunnels where the anchors go. Rows, extension, tees, wise, active wrist and hand motion. As we move a little further into it, again, we're telling them, these guys, like, hey, they have split through your flexor mass. You need to be careful yanking, pulling heavy weights, those things. And then we're trying to get busy with the core and balance stuff very, very quickly because their ramp up is going to be much faster. Weeks 4 through 10, again, progressing through your rotator cuff and scap stuff. And by week 6, we're doing 2 hand plyos. By week 8, 1 hand plyos. And we're putting a baseball in their hand at 10, likely 12 weeks. And then building up at 6, 7 months, they're back in the game, okay? So one interesting thing that we see in these guys is around when we get to the 90-foot phase of throwing, a lot of kids will have a little bit of stiffness. And our current working theory on that is because that ligament doesn't have any the internal brace component doesn't have any laxity to it. It doesn't ever stretch. It's just a fixed link. And as you lay your arm back, you're going to feel that, and guys will feel that stiffness. They get through it. They all do, but we start educating them early. Just expect that when you get to 90 feet, you're going to feel something with that. Okay, again, why is it faster? Other than the flexor mass, there's no physiologic remodeling that has to happen versus a reconstructed graft. And is it better? I don't know. I can tell you kids come back really quickly. We probably have 30 of these kids right now in our clinic. Again, as we talked about, we do see a fair number that have some irritation there. So as we move into UCL reconstruction, it's been known as the gold standard for a long time. It's changed a lot as well, although the rehab really hasn't changed other than we've gotten slower with the timelines, okay? The goal of the UCL reconstruction is to restore normal anatomy and valgus stability in the elbow. No matter where your doc trained, I think it's important to know where they trained and know what the procedure is for a couple of reasons. But just know it really doesn't matter for your rehab timeline. We're still treating these things the same way because that reconstructed ligament needs the same period of time to remodel. Excuse me. So Andrews for a long time did the osseous tunnel technique. The thing to note there, and we'll show you on the next slide, is that they always move the nerve if it's a modification of that original Job technique. So everybody that had an Andrews surgery also had an ulnar nerve transposition, where all of these other procedures, docking, interference, the new hybrid reconstruction with internal brace, they're only moving the nerve if kids had nerve symptoms beforehand, okay? So this is just some stuff talking about the strength of it. So the difference, one of the major differences for a UCL reconstruction versus like an ACL. You tear your ACL, what do they do with your old ACL, the stump that's in there? Take it out, right? So these UCLs, they don't take it out. So if you have the newest technique where they're doing UCL reconstruction with internal bracing, you also have your old ligament in there, and they sew those together, okay? Again, just trying to give you the biggest construct to resist valgus as you can. So here's a picture of the original technique, modification of Job's original technique from '74. Basically, they're taking the graft and doing a figure 8 with that. Because of the way the bone tunnels are drilled, you see on this side there's the graft arm here. They're drilling through the humerus in 2 spots, so where the nerve was, they take it and move it forward so that they don't puncture the nerve, okay? Versus the docking technique, they use 1 tunnel on that side with 2 little drill holes, and the little lines that are vertical, hard to see, they take the graft and stick it through one tunnel on the humeral side and tie it. Now, why is that important? Because when the swelling goes down, these kids will reach right behind their medial epicondyle and they'll feel a bump and they think it's scar tissue and they want to dig on it. And it's not scar tissue. It's the knot that's tied over that tunnel, and it's not going to go away. It's a fiber wire suture, okay? So it's important to tell these kids that when the swelling goes down, they're going to feel that little knot, and what Dr. Lintner tells them is that that's good. That's holding your elbow together, okay? So again, for me, the technique doesn't change the overall timeline for rehab. The tissue still has to heal. The graft still has to mature. But I will tell you, your rehab needs to focus on what's important for baseball players. This is the time where guys that have issues and haven't been on a program, the reason kids come back and throw harder after TJ, especially our high school kids, is because they spend 6 months strengthening, doing stuff they would have never done before, okay? So it's really important. And we get kids sent to us to assess if they're ready to throw that didn't do the rehab with us. And I will tell you, there's a lot of, as you guys know, there's a lot of crazy shit out there. There's a lot of people doing a lot of crazy stuff, none of which is specific to baseball, none of which is specific to the sport. And you see it across all the sports. But baseball, I think, has gotten even a little bit more Wild West with some of this stuff. So make sure, and we'll talk about that when we talk about the rehab timelines. The UCL that's healing has to have, it needs to be stressed, and it needs to be stressed at the right time in the process based on tissue healing, or you don't get the overall collagen strength that you're looking for. And you know you're going to load it significantly and repeatedly when you start pitching in games, okay? So it's very, very important for that. If guys have had ulnar nerve transposition, it's just important. Just remember, too, if they've had their nerve moved, it's typically going to be moved right to your medial forearm. So don't do a lot of flexor digging on their flexor mass, because that nerve's now sitting over that. And most of the skinny kids, you'll be able to find it once the swelling goes down. It's going to be sitting in the medial. They create a little fascial sling and just hook it right underneath the skin, okay? So as we look at the rehab overall, it doesn't matter what technique. These are the minimum things that we need to accomplish. Now, for the first 6 weeks, we got to let the graft heal, okay? We got to give it time. We can't be cranking on these elbow. We can do range of motion, but we've got to do that slowly. We got to start working on strength of the elbow, but also the cuff, scap stabilizers. And we really don't want to load that ligament with any valgus stress for a period of 16 weeks. That means no throwing for that long, okay? You got to educate these guys. I see a lot of guys from Keith Meister in Dallas, the Rangers doc, who's, if you follow baseball, that's where a majority of the professional baseball players are going to one of 3 places. They're either going to Allcheck in New York, they're going to Meister in Dallas, or they're going to Elatrash in LA. And that's because the agents typically drive that. But we don't throw for 6 months with those guys. So they know coming in they're not going to touch a baseball for 6 months. And you've got to be able to continue to emphasize why that is. And then as we start loading the elbow, we've got to make sure that their mechanics are good. And we've got to gradually increase those loads to the elbow, and we'll talk about that. And the throwing program, and the way that we teach all these kids, is the throwing program is the strengthening for the ligament. For the period of time that we've done strengthening, until we get up to throwing, everything we've done is strengthening your forearm, your biceps, your triceps, your whole upper body. It's all muscular strengthening. When we start the throwing program, that is the strengthening for the ligament. So we're going to stress the ligament with a set number of throws from a set distance. We're going to take a recovery day. And then we're going to increase that stress, and we're going to continue to do that over 4 to 6 months to build that tensile strength back up in the ligament, okay? So still a common myth out there, you guys probably hear this, well, my buddy had TJ and he's great. Should I just have the surgery now? Probably not the greatest school of thought, okay? There's no guarantee of these outcomes. And the interesting thing when you look at outcomes in baseball, specifically in high school kids, if you're a high school freshman, what's considered to be a success in the literature is return to prior level of play. If you're playing freshman baseball and you have surgery, I can tell you right now, we can give you a 90% chance if you have surgery, we can get you back to freshman baseball, right? But there's no predictive value of where these kids are going to end up. Nothing says that if you have it fixed, then you're going to be better off, okay? It's just not the case. So it's important for your parents too. So as we protect that healing ligament, roughly the earliest we throw is at 20 weeks. That's a couple of our doctors, but most of them are around 24 weeks. Rotator cuff strength, posture, scap, balance. You can do a lot of work in that period of time leading up to there for those 4 or 5 months until you throw. Then again, as we get into the interval throwing program, we'll talk about some of that. This is just kind of a basic outline of our timelines. We typically will see at weeks 4 to 6 the brace. Typically at week 1, we open the brace. For the first week, we'll lock them at 90. Some docs will put them in a posterior splint. And then at the week 1 mark, we'll open that brace 30 to 90, and we open it 10 degrees of flexion extension per week. So over the course of the next 3 to 4 weeks, you're roughly at full range of motion by week 5, 6. And at 6, the brace comes off. Okay? And then we'll go through some of this more specifically in just a second. So what are the success rates? They've hovered around 80, 90% in the literature for a first-time UCL. We said if the revision guys, it's 62 to 68. But again, what's a successful return to play? It's the same or higher level. So again, your high school freshman, he's got a 90% chance of going back and playing freshman baseball, okay? These numbers are way better than shoulder surgery in baseball players. Do you have any idea why that might be? The biggest thing is mechanics. If you look at the mechanics of a shoulder throwing a baseball after a slap tear or a rotator cuff tear, their mechanics change, they lose motion, and there's no statistical significance in difference in range of motion pre or post-op. Even if they lose a little motion in their elbow, their throwing mechanics are roughly the same, okay? Average return to play is around 12 months. In the MLB, this is increasing. Right now, it sits around 17 months. And part of that reason we've seen the shift is because these guys throw so dang hard, right? You got a guy throwing 101. You would rather take a little longer building up his volume. Okay, and here's what we talked about. This was a study that Fleissig did. They actually came to the Astros minor league side. As part of this, they went down to Florida. They went to a bunch of different places. They took 80 kids. They put them in a control group that had never had TJ. The other group had surgery, and they looked at their throwing mechanics. And essentially, no difference in their shoulder and elbow range of motion, and no significant difference in their elbow and shoulder biomechanics. And again, there's plenty of studies showing that's not the case in shoulder surgeries. So this is where we're at now, UCL reconstruction with internal bracing. And over the course of the last 15 months, all of our docs in Houston have now gone to this. If we're going to do it, we might as well put the internal brace on top of there, okay? So all of our elbows from our Houston Methodist docs, from our outside docs, from Dr. Meister, and essentially the way he puts it, it's a belt and suspenders. If we're in there, it doesn't delay the healing. It may increase the strength overall. We might as well do it. And all of my professional guys for the last 18 months, except for 2, have had the combined technique, okay? Right now, right now we're following the same protocol, but there may be, to be determined if that's going to change at all. So what does the literature say? Biomechanical comparison of just doing a docking traditional UCL reconstruction and then also adding the internal brace. And the important thing here, the take home is if they have an internal brace, it provides superior stiffness. So at what's considered to be time 0, immediately after post-op, that elbow is stiffer than it would be from a valgus standpoint than if they had not put the internal brace in. Okay, so it gives us a little bit of extra level of protection with that. An increased max torque to failure, it's stronger, and it's more similar to the biomechanical performance of the native ligament. So it just adds to it, adds to the structure, okay? So again, more resistant to gapping, combination of suture anchors and fixation, screw holes did not weaken the overall construct. Because our original thought was if you're drilling to put that graft in, and then you're drilling 2 more holes to put the internal brace in, is it going to risk fracture in the medial epicondyle? And the literature says no. And we haven't seen any, so knock on wood, that stays that way. So questions to be answered down the road from a rehab. Since the internal brace improves the stability at time 0, should we change our timeline at all? Can we add anything sooner? I don't know the answer to that. Right now, we're treating it exactly the same. And will it make their elbows stiffer? So far, the answer to that's no. So when we talk, now we're going to talk in some specifics of the rehab and give you some of kind of some clinical caveats that I think are important. Usually with these post-op elbows, you do not have to work hard to get their range of motion back. If you're cranking on them, you're going to have more problems getting their motion back than if you're helping it along and following those timelines, okay? The only ones that have trouble are the ones that either are really old guys at the end of their career in professional baseball, or the kids that have also had a bunch of junk in the back of their elbow and they've had it scoped on top of having a reconstruction. So the guys that have a scope on top of there, they're going to, as you can imagine, they're going to be more inflamed. Their joint's going to be blown up. You've got to be a little more cautious with those guys because they're going to be a little bit slower to come along with the motion. So this is how we typically get the extension back. My favorite go-to is low-load, long-duration extension stretching. And when would I start that? Gravity assisted at about 4 weeks, just letting them hang their arm there with a hot pack. Hey, come in, let's work on your extension. Okay, also communicating them, much like the knee, you work on extension, then flexion feels terrible. You work on flexion, extension feels terrible. But by the 6 week mark, most of your young guys with internal brace or reconstruction should start getting their motion back, okay? If by week 5, 6 they're not, I'll put a lightweight in their hand, but I'll never crank on these guys. You just don't need to. It aggravates it more than it helps it, okay? So I'll start pretty quickly too, looking at their shoulder range of motion. By the time they come out of the brace, we're already getting an idea of what their cross-body adduction is, posterior shoulder tightness. I am a little more careful with doing a true internal rotation stretch because you're torquing the elbow. But if you're interested in a couple techniques, just send me a message and I can show you some modifications of hand position where you can work on that, where you're not stressing the ligament, okay? So other caveats, avoid aggressive power grip, especially if they've had a reconstruction, because as Dr. Lintner said, we're beating the crap out of the flexor mass. He doesn't even want us to do soft tissue work at all, not even light flush for the first 6 weeks, because he said, you know, if you watch the surgery done, they're splitting through the flexor raphe, but they're cranking it wide open and they are really digging that, getting down deep to be able to put the ligament on there, okay? And so in 2 cases, I've had guys, they take that flexor raphe and sew it back together. It's kind of a split between 2 parts of the flexor mass. In 2 cases, I've had guys do too much too soon and actually open that up. And when they throw, the way we knew it is when they would throw or do forearms, they would have a muscular herniation through the fascia. It would bubble up in their forearm, okay? Kind of a gnarly looking thing. You can have guys that'll tear their flexor mass or really strain their flexor mass, so it's very important to educate them of like, don't be a bonehead, be careful with this. They did a lot of stuff to your flexor mass. So for us, we will use BFR for this, if any of you guys have that as an option, but typically I'm gonna wait a minimum of 4, likely 6 weeks before. So what BFR does is allows you to use a lower load, create a higher stimulus, perfect application for that in these guys, because we want to get their forearm strong, but we don't want to overstress it. And this guy actually laying on the table, you can see how he was a revision TJ guy, major league player. And part of the reason we lost in the playoffs in 2018. So cuff and scap strength, typically at week 3 or so. For us, the first couple weeks of post-op TJ rehab, you're doing a little bit of range of motion in their brace limits. Okay, 30 to 90, we let them move in the brace, and we're doing active wrist and hand stuff, just stuff to stimulate blood flow, get the swelling out of there. By week 3, we start doing cuff, you know, some of your standing flexion, scaption, bent over rows, prone horizontal abduction, start getting their shoulder moving. But we're still protecting that elbow for those first 6 weeks. This happens at week 1, your first post-op visit, if you just had an internal brace, because we know at 12 weeks we're going to have a ball in your hand. So plyometrics is a really important piece of this, and if you look at those references that I said on drlintner.com, the new protocols that we published on there, they show you what weeks to start stuff and kind of a good clinical flow of progression of your exercises, progressive reloading of the ligament, okay? So if you're going to throw at 20 weeks, somewhere 4 to 6 weeks before that, we'll start two-hand plyometrics, then go to one-hand plyometrics. But most protocols are around week 17 post-op. We start two-hand chest pass, two-hand diagonal chops for a couple of weeks, and then we start adding in the single arm, plyos here, wall dribble, whole myriad of things there, okay? Really, for me, I don't think you're stressing the ligament as much as you are prepping the shoulder to move at a higher speed. Because if kids take 6 months off and you haven't thrown in 6 months, and then we put a ball in your hand and you start moving your shoulder quickly, most of our guys, if you don't go through the plyometrics, you're going to have shoulder pain, not elbow pain, okay? Throwing program, critical to the successful return to play for injuries for the UCL. It's a progressive reloading of the ligament. It is the exercise for the ligament, and failure to follow a good stepwise throwing program or trying to skip steps and ramp back up too quickly is the most common reason that kids continue to have problems, okay? Avoid throwing too hard too soon. We use a pocket radar with all our guys. We have some velocity charts that, you know, if your fastball is 85 to 90, here's the percentage of when you get to 60 feet, 75 feet, 90 feet, 105, this is how hard you should be throwing. Your averages and your max speed, so that we have an ability to do that. And if your kids are playing baseball in the summertime or at the PG events, they all have access to a pocket radar, okay? So what is our criteria to determine if they're ready to throw? Adequate healing time being number one, normal pain-free range of motion, normal cuff and scapular strength, improved posture, and then a proper rehab progression. So we added that in because, like I said, we get a lot of kids sent to us to determine if they're ready to throw. We have a thrower's readiness index that I'll show you in just a second. And when we assess these kids and look at it, they've skipped whole chunks of the rehab process, okay? And so if they've done that, then we've got to redo that. So here, and I'll send this to Sean to send out to you guys, here's the components of our thrower's readiness index. We take some demographic stuff here, subjective stuff. Are you pain-free, yes or no? Have they been consistent with rehab? And then, do you have the confidence to throw? Are you ready to throw? If you say yes, great. If you say no, we're going to take a little longer, okay? And then special testing, is their joint still swollen? We're going to take their elbow up and crank on it a little bit, okay? Make sure it doesn't have pain. We're going to look at shoulder special testing, posture, how their scap moves, and their elbow range of motion. And then some functional tests that we do. These are all core and primarily core and shoulder endurance. We do a single leg step down, prone ball drop test, single arm ball throws against the wall where they're dribbling, low intensity towel throws where they're going through their throwing motion, a side plank, and a prone plank. And we have norms with these. So here's what our sheet looks like. Our docs want to see this before our kids start throwing. They want us to look at what's their shoulder range, is there any loss of mobility, and then we use a handheld dynamometer to check their cuff scap strength. We look at ER and IR at the side, as well as prone at 90-90. And we're looking for ratios there. So what are we looking for? Again, full non-painful range of motion, a glenohumeral internal rotation deficit of less than 15. Do they have the confidence? Is their ER to IR ratio at 0 and 90 greater than 70? And then, is their strength back? And then there's some other things on here. These will all be on there for you. Okay, so how long should a throwing program be? I get asked that question a lot of times. So if it's non-operative, you can pretty much assume you need at least 1-to-1 of how much time the doc said you need to be off to the time you need to build up. And for those of you guys that take care of high school baseball players, this is about to be real important, right? Starting next week. Because we're gonna have kids that didn't prepare for the season, have something flare up, and then you're gonna have to figure out how quickly you can get them back, okay? So if they're down for 6 weeks from a mild UCL strain or a medial elbow growth plate issue, we're gonna tell them it's gonna take at least 6 weeks to build you back up to be able to either throw on the mound or to throw hard from outfield or catcher position, okay? What the kids don't hear in this when they go to the doctor is they tell them they're off for 6 weeks. they think they're ready to go back in the game at 6 weeks, right? And they don't think about that other build-up. With an internal brace, again, as we talked about, you start play catch at 12 weeks. By 24 weeks, you're back on the mound. In a reconstruction hybrid, it's going to be anywhere from 20 to 24. Typically, they build back up to the mound by 8 months, but to build the volume back up to go into a game at the college and professional level is usually closer to 12 months. Position players, much sooner than this. So your high school, middle infielder that has TJ can probably be back closer to 10 months. So this is just a rough outline, and if you have questions, you can email me, and I can send you about 1,000 different throwing programs. But it's a rough outline for this. Typically, we start throwing 3 days a week. We'll start at 45 feet, 25 throws. We'll do that 3 days a week. That's kind of our intro to throwing phase, and then most throwing programs are following a 60, 75, 90, 105, and 120-foot progression. And the way that we build those is 1 week of one set of 25 at 60 feet, then a week of 2 sets of 25, then a week of 3 sets of 25, then you go to increase the distance to 75 feet and go back through the 1, 2, 3 sets. That's why the throwing program takes forever, right? Because you're 3, 6, 9, 12, 15 weeks at a minimum to build back before we put you on the mound. And that's without any bumps in the road. If kids can't get through it without soreness or pain, then you got to repeat those phases. So again, it's the most important part of the rehab. 2 of our guys did a study a few years ago where they surveyed a bunch of rehab professionals, and they said, how often do you use a throwing program as part of your rehab? What do you guys think the percentage was for that? Not good, that's right. It was 40%. So 60% of the time, we're just telling these kids, just, hey, wing it, go back out there, okay? And I don't think that's a real efficient way to go about that. So again, I don't care which version you use. There's the long toss base ones back to 180 feet. We typically will not use those in the post-op guys because we know at 150 and beyond, 180 and beyond for sure, there's increased valgus stress and increased kinetic stress at the shoulder and elbow, and we don't want to do that in the healing guys. So your guys that are, hell-bent on long toss as part of their stuff, we tell them once you've gotten back to pitching and you're healthy, then we'll worry about long toss. We're trying to get you back into play as quickly as we can. Okay? So in summary, you got to have good scap, cuff, and rotator cuff strength and internal rotation range of motion. For your players who are going outside of your teams or your organization to do their rehab, just make sure that they're doing the right stuff because, again, as I said, there's some crazy stuff out there, and we need athletic trainers and PTs who understand this. It's really, to me, alarming at some of the stuff that these baseball kids are exposed to through their rehab that's just not effective. Improper throwing mechanics will increase the forces on the elbow, and again, all these other components, balance, your progressive reloading with the throwing program, because great rehab with poor throwing mechanics is going to result in re-injury. And again, remember your throwers. So a couple of my thoughts on this. Again, I can't understate. I have a son that's 15-year-old baseball player. No, he's never played year-round baseball. Yes, he's played multiple other sports. No, luckily, he has not gotten hurt yet. And no, he does not pitch. I think the overuse part of it has been the biggest eye-opener for me the last 2 years getting ready to go to high school because you have to play a little bit more baseball. You have to do a little bit more. But the craziness of how many games and how many exposures these guys are getting at an age where their growth rate is the highest, their maturity level, physical maturity level is varied between each kid. Is really crazy. And we also have a lot of high school programs in our community, and you guys can probably say this, that are really using the weighted ball stuff and focusing on, heavy velocity stuff. And, I get asked that question a million times. Is there utility to weighted ball stuff? Yes. Is it a one-size-fits-all, and should it be the same for every kid? I don't think so. I mean, I think that's dangerous. There's plenty of other studies in the literature that say if you just do cuff and scap strengthening and add core stability and lower body strengthening, you can increase your velocity. And Kevin Wilk and Mike Reinhold did a study on that a few years ago and said, yes, in all these categories we can do that. And guess what? In the weighted ball program too, we can get these kids increased velocity. But in that group alone, compared to the others, there were more injuries, a statistical increase in the number of injuries. So as healthcare professionals, we got to be careful with that, okay? Now, there's a time for that for sure. So again, the huge variability in size, and the other thing that's now an option for these kids is to be a pitcher only at a young age. We got a lot of 14 and 15-year-old kids like he's a PO. He only pitches. But what does that mean? That means he's taking lessons, pitching lessons 3 or 4 days a week. Every weekend that you play, he's pitching 1 to 2 times, sometimes more. And so those kids, I think, have to really spend some time educating them as well. Okay? My thoughts again, if you can play multi-sports until high school, I think it's good for you from a motor development, athleticism, and relative rest standpoint. Make sure that you're watching out for your kids with this extreme overuse and understand the healing timelines. It doesn't matter what we take care of surgically. We can't change the physiology of tissue healing. And if we design our rehab programs around that, it's really relatively pretty simple, right? We just can't exceed the tissue healing timelines, okay? Other thoughts, questions? Yes, ma'am. Yeah, that's a great question. So there are those soreness rules that are out there. What I tell guys is if you can't continue, if you're playing catch, let's just say we're going to do 2 sets of 25 at 60 feet. Start warming up, playing catch, nothing's bothering you, or you might feel a little something, but it gets better, and then you can do the second set fine. I tell guys all the time, if you play catch today and after we're done you have a little bit of soreness, but tomorrow you're not sore, and then on Wednesday you can do your throwing program, then you're probably fine. But if you throw your throwing program today, you can't brush your teeth tomorrow morning, and you're really worried about throwing after that, then that's a problem, okay? And that, I think the way that you educate them, the way that we've avoided a lot of that is by using a pocket radar. Because it used to be, we would say, hey, throw 50%, hey, we want you to throw 50%, and that's all subjective. But now we can put a number to that. Say, how do you throw? My fastball is 85. Okay, here you're going to throw at 52 to 54, and I'm going to we're going to have somebody sit on a bucket or put on a tripod and show them every throw so that all the volume is at the right intensity and you really limit how much of that happens. Okay? Yes?